two apologies today. We have two Neds who are both away. It's half-term week. Alice Cooper and Damien Venkatsamy. And two governors have given apologies, Andrew Stephen and Annette Bridgeford. I don't know if you have any others now, Manisha. No?
Yeah, we've got apologies from Mo Latif as well, Ellen.
Okay. Okay, all good. Anyway, congratulations to Mabel and fellow governors for being shortlisted at the NHS Providers Governors Conference. Well done. That was all led by Mabel. It was good stuff. Encouraging newspaper articles, encouraging people to use the hospitals during a pandemic. Good things for governors to be doing. More of them, Mabel.
Thank you very much. The credit's all to the other governors who've mainly written the articles.
Okay, well done all the other governors then who've mainly written the articles. Anyway, thank you for coordinating it and putting it together. Right, minutes of the meeting on the 3rd of March. You all happy to refer record?
Yes.
Yeah, good, thank you very much. And the action log, everything appears to be complete on the action, showing green. If you're happy, we'll just move on. Okay, good, thank you very much. I would have talked a little bit about the planning round, but you've got that as an agenda item today, so I'm not going to talk about that. And I'm going to move on to Debbie. I just need to record. Trevor, you have to leave about 11:30, I believe. Yeah, so if we're running slightly late for any of Trevor's items, we might just shuffle the agenda to accommodate him before 11:30, which is primarily the ones on item 8, I think it is, isn't it? Yeah, item 8. So, Debbie, over to you.
Thanks, Chair. Good morning, everybody. So I'm going to start with an update on COVID. So today we've got 2 COVID positive patients in our hospital. They've both been in around about 5 days. We had got down to 0 a couple of weeks ago, but that then increased to 5 and has gone back down to 2. So it's relatively stable. The hospital does feel much busier than it has done. A&E activities definitely increased within the organisation, and especially in the evenings. And the majority of patients that are coming to us are those presenting with minor illness, and it's working age adults mainly. So when they finish work, they're coming here, telling us that they have been unable to get GP appointments, but really difficult to triangulate that information, because when we do speak to the GPs, they do have urgent appointments during the day. So we will be doing some work within the system with healthcare partners to be able to stream some patients away from A&E, so that we start to change the culture of the public just turning up to A&E to be seen when they don't necessarily need acute care. We've also started to welcome some of our visitors back, as you will have seen in the press, and also some staff who've been shielding have started to come back to work as well. Outpatients and operating work has also recommenced, so that's really good. We are working across all of our theatres except 2. We've got 1 theatre out because we need to keep 1 theatre for COVID patients. That's known as a red theatre. And the other theatre we haven't quite managed to staff as yet due to some of the vacancies that we've got in theatres and with the anaesthetists. But what we are doing is working with the private sector and NGH to see how we can together staff that theatre and get more patients through. Another thing just to tell you about, a couple of weeks ago, we launched a staff listening event. This is an open meeting. It happens once a week, and it's for any member of staff to come and talk to myself and the exec team about their ideas of how we can make life better at work for them and also for the patients. So things that really frustrate them, things that they want to change, duplication. And the first couple of events have been really well attended, mainly by ward staff. But what's really important here is that we don't just listen to what our staff are saying. We listen and then feedback with the actions that we've taken. And we'll be doing that through formal mechanisms such as our monthly staff briefing, and also more informal means such as sharing stories when we're out and about in the organisation. Some of the themes that we started to tackle within that space are digital, such as slow digital equipment, slow computers, documentation. So the staff is telling us that sometimes that's complex and difficult to understand. And some of our staff are also telling us that they're concerned about staffing levels. So there's some of the themes that are arising so far. So just want to also let you know, over the past couple of months, we've made some new appointments, and really pleased to let you know, first of all, at the group level. So we appointed John Evans as Chief Finance Officer several months ago. You'll recall that. He starts with us on Monday next week. Teresa Latang, who is the Group Director of Communications, she started with us yesterday. And then reporting directly into Teresa is two heads of communications, Sandra Taylor and Alicia O'Donnell-Smith. Sandra will be based at Kettering and Alicia at Northampton. And I think with that strengthened comms team, we will really start to see a difference in both how we're communicating internally and also externally. At KGH level, Rabia Imtiaz took over yesterday as Interim Medical Director. Rabia has been the Deputy Medical Director for several years. Ian Roddis was also appointed substantively to the Digital Director role last month, and Paula Fitzpatrick to the Director of Workforce role for Kettering. So really well done to all of those, and I'm really pleased that they're part of the exec team here at Kettering. And finally, I think it's looking really nice outside at the moment. We've definitely seen a change in the weather, but what's important now over the next few months is that we start to plan for winter. And it's imperative that we do that because we are likely to have a challenged winter. We'll be expecting an increased numbers of flu patients and increased respiratory illness in children. So I'll bring more information on our winter plan as we go through the committees over the next few months. But I'm happy to take any questions, Chair. Thank you.
Okay, thank you very much, Debbie. Anybody got any questions at all they wish to ask? Let me just check on hands. I don't have any hands up at the moment. I don't have any comments at all on anything. Give them another few seconds. No, don't know. Yes, Gail. Well done, you got there at the end.
Yeah, thank you, Alan. I put a comment in the box, and it was really just from Deborah's point of view. A family member has tried to access GP practice within the last 3 weeks approximately, and told still no face-to-face appointments. So
yeah,
clearly issues out there.
Yeah, so the GPs are starting to come back face to face, so we will see that more and more. But they are just as hot as we are, so they are just as busy as we are at present. But so they're all working 8 till 6. There are certain GP practices within the county who've got extended hours, and of course there is an out of hours GP service. So if it's an urgent opinion that's needed, that will be triaged either via the phone or face to face, and that decision will be made by a GP. But if you want to send me details of that particular practice, I'll certainly be happy to raise that.
I think it's just general issues, and you're hearing from the public that they're still really struggling to get the telephone calls answered to actually speak to anyone. They seem to be ringing continuously. And I tried just because of the feedback I'd had, and I gave up in the end. There was no response.
Yeah, thank you.
Mabel. Mabel, I've lost you.
Sorry, lot of difficulties about seeing a GP from people I represent, plus patients, not just in this county and area, but elsewhere. So it's a general thing. I've just been telling people to phone 111, and quite honestly, I've had a really good experience of phoning that. Because if it needs an appointment, they've sorted one out. If it was a prescription, they've sorted that out. And I think that's worth telling people.
Yeah, thanks, Mabel. One of the things that we will be doing is having a digital kiosk, a bit like when you go to your GP surgery to check in, but this kiosk will be at the main entrance of A&E. And as patients are booking in, if they are not needed, they will be, or are not needed to see an acute physician, they will be diverted to the kiosk to absolutely go through the 111 route. Because we do need to start changing the mindset of people of just turning up to A&E.
Wendy.
Just to say on this point, because as health watch, which I'm speaking now, is the point that there have been so many complaints or worries and concerns with regard to the point you're talking about, lack of being able to contact the GP, speak to one, etc., etc. Health Watch are doing a piece of work starting in July with regard to looking at how this can be, how we're moving forward. So if that's any reassurance to the people that are contacting you.
Okay. Thank you very much for that. We've still got any hands up? No. Wendy, if you could take your hand down, that would be a help. Thank you. I think obviously two things can be true at once. GPs can be very busy and there can be no appointments. And maybe both of those things are true. I think there's quite a lot of sociological stuff to be done about how patients have changed how they access services during the last year and a bit. There's undoubtedly been the case that people reached a conclusion GPs were shut, which they never were, but that was certainly a view people had. And then hospitals, of course, were seen as dangerous places. So people have definitely changed their behaviour. There's no doubt that 111 is a good route to go. It will get you an ED appointment, or at least a slot in which to attend. And it will tell ED you're coming, and it will give them a sense of the priority and all the rest of it. So 111 is definitely the route to go. And I think that's just a trend for the future that has been speeded up with COVID. You'll have heard secretaries of state before saying things like talk before you walk, which means phone 111 before you go to GP or whatever. So I think that message, if you get an opportunity to give it, is a good message to give to anybody. 111, please. Right. Don't see any more. Board committee summaries. Quality and safety, Chris, and then Gail if she has anything to add. Chris.
Thank you, Alan. We had a meeting on the 18th of May and we noted we had a COVID update, but you've had one this morning. I'm sorry to have to report that we had a never event reported to us, to the committee, and that's under investigation. We did note, however, that this is a never event. This never event is very similar, if not identical, to never event or never events that have happened in other organisations. And is this a regional, national issue? We discussed falls and noted the further work that's been done there. We also took comment on the performance and noted that bed occupancy was now at 89% and that the 52-week waiters had again reduced to 0. I suppose the big thing was that we reviewed the draft quality report, which is a really excellent document and worth a read. And then we noted progress on clinical effectiveness and that the Get It Right first time, the GIRFT project was restarting, having been paused during the last year. So those are the key items from the committee. Alan, thank you.
Thanks, Chris. Gail, anything?
Just to say, with regards to the quality report, that governors obviously have a session to review that and give comment. And the only thing really, I suppose, in line with last year, and we'll have that conversation at the meeting, is about a summary document because of the massive amount of detail in there, which for the ordinary member of the public would be rather too much. So we'll follow that up at our meeting.
Thank you. Very helpful. Anything else? I'm going to keep going on these. PF&R is Trevor, not Damien, because Damien's given us apologies. Trevor.
Thank you. Yeah, so PF&R, if we start off with the operational side, we've got on operational side, as you've heard from Debbie, the pressures around urgent care The one item that we also heard about was the opening late March, early April of the new Miami service, which sounds in the current weather as an ideal service, but it's minor, I'll get it right, minor injuries and minor illnesses. So it's part of the outpatient department that's been dedicated to doing the minor injuries, and actually a lot better environment than had been there, both for treatment and for the staff to work in. I think the item that we didn't discuss but we're alerted to are the 10 new measures that are coming in for ED in terms of national measures, and I think that's probably something that we need a separate discussion on at a future meeting, so governors are briefed on exactly what those measures are and how they're going to affect us going forward in managing our ED department. On RTT, April there was 7 52-week waiters. In May there was 0, which nationally is an extremely good position. It's not good for those individuals, we know, and the focus is on trying to get the next cohorts down, aiming at sort of, particularly in the middle there, at 38-week waiters. So it's a clinical need, clearly, but you do get these bulges, and it's making sure we're dealing with those bulges. At the same time, it was reported the amount of referrals going up, so the amount coming into the system's going up. So whilst our percentage was 73–74% in terms of the 18-week waits, that's clearly in the context of building pressure in terms of the number of new referrals coming in. So it is about the urgency of treatment and also dealing with those long waits. And as part and parcel of those, we are dealing with a few patients from outside the area to support other local systems as part of predominantly East Midlands in terms of dealing with those that are in need and where we might have the specialist skills and capacity to deal with those. Cancer and diagnostics, not where we want it to be, but they are improving. There's a phrase called insourcing, where we are on ophthalmology bringing in external expertise and facilities to support dealing with some of these areas. And on diagnostics, we heard that the trajectory is that we should be hitting targets in July. So we're keeping a very close eye on that. And lastly, on the operational side, super stranded, down to 67, but the target's 38. So the focus on Wednesdays is very much dealing with the longer stay patients, both not just ourselves, but with social services. And I always get the wrong way round, but I'm going to say age concern, I've probably got it the wrong one. Dealing with looking at how those patients can be moved on to appropriate settings. I'll pause briefly there. Apart from anything else for breath, I'm losing my voice here. Any questions on the operational side?
Peter, anything you want to add?
Thank you, Alan. Just a couple of points. Firstly, I think there's a lot of material going through that committee, and I was quite impressed how it was kept quite succinct and managed very successfully through to the end. A slight overrun, but nevertheless, it was a very informative meeting. The other point I'd raise, which Trevor hasn't raised, is the fact that we appear to be suffering quite a bit with mental health patients, and there was a conversation around getting some support from the other trust in Kettering to give us a little bit of a leg up there. So I'm not sure where that's gone to, but that was quite an interesting comment that we discussed at the time. So that was about it for me. Thank you.
Thank you, Peter. There's no doubt the mental health services are also under a lot of stress, and don't need me to explain why that's the case. You were going to go on to something else, Trevor, I gather, because you said pause for breath.
Finance. I was just going to briefly touch on finance, because the bulk of the finance is actually will be picked up, I think, in the planning discussion. The key there, though, and the finance is it isn't business as usual as it was in the past. We are in this transition to the new way finance is going to be working in the NHS. The first half of the year is going to be quite different, but then exactly what's going to happen in the second half of the year is still unclear. I think the key there is that we keep the focus on providing value for money for services and making sure that the controls we've got in place for appropriate spend and value for money are maintained. If I just pick up briefly on the mental health, sorry, Peter, going back on your mental health point, Debbie very helpfully shared with me some numbers about the increased investment this year in mental health in Northamptonshire. Unfortunately, half of it's non-recurrent, not all recurrent, but there is an amount there which is to support the acute trusts in liaison services and also to deal with some of those that are coming in to our service to make sure they don't come in, so supporting some of the child and adolescent mental health service arts. But there is still a massive shortage, not just the money, but and my challenge back to our local services will be how will they, just as we have the problem, get the staff in to actually be able to deliver these services, because they are not just out there. But it's good news to hear it's large, and by large I mean 10% increase in mental health funding this year in Northamptonshire.
Okay, if I could just add, picking up on Peter's comment about the workload, we have a new chair of finance and performance in Northampton, and between her and Damien and Lisa Yanoff, Lisa has kindly agreed to lead a subcommittee of the two committees looking across the group at efficiencies and comparative metrics for performance, which is kind of what she does in her day job, and it will provide a very good link into the System Finance Committee, which Lisa also sits on. So Lisa will be taking a chunk of work out of the PF&R committees and into her subcommittee across the group, in particular, looking for and identifying approach to efficiencies and comparative performance metrics. And of course, as Trevor says, half two is not very far away, starts in September, and we still don't know what the financial position is, and we don't know what the ask is, what we're expected to do for that. So when you come to the planning round, Polly will be making it clear we're talking about plan for half one, which is the first half of the year. Okay, any questions on finance? No. People, Janet.
Thank you. I've got 5 things to bring up for governors. Meeting was last week, and it was actually the first time that we've met jointly between Northampton and ourselves as a committee in common, and that's the way forward now. Actually, I thought it was a really good meeting, really discursive, people really airing views and opinions, and I think that made for a really good meeting. We received assurance in respect of progress and actions towards the delivery of the group people plan. We recognised there's a challenge and made some points about advising about managing expectations. Second point was that we noted the requirement for cultural change to enable successfully delivery of the group work. And our trust in Kettering, you know, it's important that both parties are talking together, and that's really obvious in the way that Mark and his team are trying to go forward. We reviewed the group workforce planning and process ahead of the final local health system submission, and acknowledged that actually this should be a really great way of looking at the available workforce across the system. Many of you will be aware that we've often borrowed from Peter and Paul and ended up in great difficulty. So this way, I think looking at some of the opportunities that affords us across the group, but also across the local health system is really important. And reassuringly, Mark is obviously a really important part of all of that work. One specific thing I'd like to raise to you is around the integrated governance report, particularly around vacancies and looking at recruitment. And you'll see on that a number of things that are being done to mitigate against any risk to our overseas and international nurse recruitment. And I'm pleased to say that the trusts are working with both national and regional groups to address that. The final thing is that the nursing, midwifery and allied health practitioners strategy was discussed. It has been to the committee previously, but it was discussed prior to going to Kettring's board last week. Interestingly, the medical directors were also engaged within that and looking at potentially what that means in terms of addressing both medical and healthcare science numbers going forward. So again, I think a really good discussion, and one that I've not experienced in that way previously, where I think I've seen such really good engagement from all of the professional and specialist leads for that discussion. So I think the engagement across the piece means that we are getting a better quality of conversation around workforce. Thank you, Chair.
Okay, thank you very much. Sheila, anything to add?
Yes, just to say that I thoroughly agree with everything Janet said about how well the meeting went. The only slight reservation I have is it is so enthusiastic. People are really talking to each other and listening and sharing ideas about good practice. And I just think we need short-term achievable goals on the way to the big one at the end.
Okay, thank you. Any other comments anywhere? Not seeing any. We'll give you everybody an opportunity at the end before I move on to pick up on all of these. Audit, Trevor.
Just very briefly on audit, the key things there was we took a discussion on the value for money decision, and both because of the trust's financial position improving, the restructuring of debt across the NHS, and also the rules for value for money changing. We were absolutely supportive of giving that going concern statement to the board, and that will form part of the accounts. We are re-meeting for the final audit committee of this last financial year on the 28th of June. For those that attend the audit committee, note it's the 28th, not the 11th of June. This is because the audit's taken that much longer. There were a number of other policies that we recommended to the board as well for approval.
Okay, thank you. Thank you, Trevor. Mabel, anything to add to that?
No, other than it was a very slick meeting. The meetings are kept really well to time. Lots of time for discussion though. So yes, I think it's truly reflected. Okay, thank you very much. SDC, it's a bit of a calm time for SDC. And the main item, I suppose, was the travel plan, which you have on your agenda for later. Obviously, we're waiting for decisions by Department of Health, Secretary of State on where we stand in the perpetual battle to win the funds to move. But we are continuing to do the design work and all the other things in the background. We have slowed down, but it is a little bit of a calmer period in terms of actual milestone events. Peter, anything you want to add?
No, Alan, as you say, it was in the dwell period of this programme, and so no, you summarised it fine. Thank you.
Thank you very much. And finally, digital. Trevor is deputising for Alice. So, Trevor.
Digital, three main things. One was very pleased to the appointments of all the key post holders across the two trusts, so that there's leads at both ends. A major piece of work going on mapping the 104 targets that strategy has come up with, and I'm just mindful of the comment about, you know, small bits and what you can do that came up just now on the workforce. How these 104 targets are going to be mapped across what's required of the two trusts. And finally was, which is something I think you can reflect on the benefits of the group in this, comparing the risks in the two organisations around digital and actually how risk is approached. So there's neither the right way or the wrong way, but it's how you approach risk is part of the discussion around the digital committee at the moment.
Okay, thank you very much. Graham, any comments on that?
Thank you, Alan. Yeah, no, I'm always impressed by the way that you're working together, despite being in different places in a lot of areas. There was a piece of work. I mean, Trevor's covered most of it, but the piece of work on baselining, which is quite detailed and a very detailed strategy report. So, and it's being well chaired and continues to do its job well.
Okay.
Sorry, Alan. Sorry. One other thing I should have mentioned. Sorry, it was picking up on the other people's notes. Yes, and we started scanning the notes in terms of notes, the clinical notes at KGH, and that is a major step, because moving from the paper notes, the bundles, the piles, and I don't know whether you all saw the pictures that Simon took in the medical records department soon after he started, with these walls of medical records. Actually digitalizing the notes and actually making those the tool going forward is part and parcel of running a modern hospital. So we are on that journey. We're well forward on that journey. It's still a significant task to get all those notes scanned and onto the system.
Yeah. Yes. It is a major task. I mean, they're going up in the thousands a week, but it will take quite a while. When in my youth, I was the National Implementation Director for National Programme for IT, and the record in the country for the size of individual's medical records was 29 linear feet. So it was actually somebody in Manchester, had a medical record that filled 29 feet of the shelving. Now, you see, you look at that and you go, that's just ridiculous. But what is ridiculous about it is no doctor could ever look at it. And you were really relying on some people having kept up the summary sheets and so on. So the digitalization of this is not just let's free up a few football-sized pitches of space, but let's also think about how we can make this information sensibly available to people. Right. Anybody questions on any of that before we move on to strategic planning overview? Mabel.
It's just a general query, but when will we have digital ordering of patient meals and indeed staff food and all the rest of it? Because it will save waste, people will get what they want, and it's going to save staff time. So it'd be nice to know when that will happen.
I suspect we might need Alice for that, but Polly has her hand up. Good. I'm glad somebody came to my rescue, Polly.
I thought I'd help you. So, yeah, Mabel, you raised this actually. I think it was either a previous one of these. It was under the HIP 2 that you raised this, and it was a really good point. And I said I'd take it forward, and we have been taking it forward. So we have started to do a review, and we've got some external support in to do a review of our catering. So how we're doing it, is it good? Is it good for patients? Is it seamless for patients? And picking up the digital point, as you exactly asked, what is our wastage? Is our wastage related to how well we get our patients to choose their meals? How hot is it when it arrives on the ward? And what can we do? So we've started that piece of work, and I'll happily keep you engaged directly, Mabel, with that, and get your views and thoughts as we start to conclude that piece of work. So what are we going to therefore do? It would be great to have your thoughts and views into that. So I'll keep you in the loop of that. The other thing we're doing is just linking over to Northampton and comparing ourselves, because they have a different catering system, different waste. And we need to just have a look and say, well, what is the best way here? What can we learn from each other, and what can we do going forward? It absolutely forms as well part of our green agenda. So I have delightfully, and I don't mean that sarcastic actually, because I'm a very big avid supporter of the fact we need to all start going green. So I've been appointed the county lead for the NHS Greener agenda. So I will absolutely be picking up food waste as part of that as well, and happy to keep you engaged, Mabel.
Thank you. That would be lovely. We do have quite a high level of food waste, I understand, whereas some nearby hospitals have really reduced it. And I think it's really an agenda that needs hastening forward. Thank you.
Thank you, Mabel. No finer governor to be involved in it. I'm sure Polly will involve you all the time in that. David, your hand is up. David? David? No? No. No, still nothing. Okay, hand still up, but no reaction. Okay, I'm going to move on. Strategic activity and financial planning. So Polly and Anil are doing the briefing on this, and this was approved by both boards last week separately. So whenever we're good to go, Polly and Anil, if David does reappear, I'll come back and take his question on the committee stuff when we get to that point. So Polly.
Yeah, thank you very much, Chair. So yeah, delighted to be here and explain where we've got to with the system and the organisational plans for this year, or the first half of this year. So I'll provide a little bit of context and where we are as an organisation, and then I'll hand over to Anil, who will take us through some of the more detail about what that means for our financial plan and what that means for some of our support for our staff. So just to start at the beginning, just for those that may not have been part of this kind of a thing before. So every year, NHS organisations are required to submit an annual plan that sets out what you're going to be doing in the year ahead, how many patients you're going to treat, what your waiting time targets, what you think you can deliver, what that means for your finances. So it's an overarching operational plan that we need to submit every year. And the papers that you've got in your pack summarise what ours are in the context of those 3 key drivers that form part of in those circles at the beginning. So first key driver is how are we going to support our people and their health and well-being. I think Richard's about to share it actually, and their health and well-being going forward. That's that circle there on the left. We know that no, sorry, that's our bottom one. Sorry. We know that our staff have been through a very difficult year, very, very difficult, probably one of the worst ones that they may have had in their careers in the NHS. So as we start to recover back to business as usual, as we start to try and recover some of our waiting times and access for patients, we need to really make sure that we're balancing that against our staff health and well-being, and we're looking after them, making sure that they feel like they're looked after and they're rested and recuperated, and they've got all their summer holidays and spending time with their families that they perhaps haven't been able to do over the last year. So that's one of our drivers. The other one, of course, is our patients. Absolutely. Some of our patients nationally, you'll all be aware that patients are now waiting longer for planned treatments, elective treatments, than they have in many, many years. So that's both for cancer treatments, but also for non-cancer treatments. And so what we really want to do is make sure we have got all the plans that we can in place to be able to recover some of those waiting times. So to get our patients the care that they need as quickly as they can get it, but as safely as they can get it, protecting infection control and other things. So again, some balances and some key drivers there. And then, of course, the third one is how we're going to deliver financial balance when you take into consideration the last 2 that I've just talked about. And you can see some of the kind of key themes that were just examples on the right hand side of the things we're going to start to need to consider. So we are going to need to, as per every year, start to think about how we become more efficient and our cost improvement plans, how we deliver operational efficiency. But how are we going to do that whilst we're also supporting a growth in our workforce, whilst we're also supporting, getting our patients treated as quickly as possible. So those are some of the things that we are going to need to consider as we go throughout the year. We're going to need to keep a very close watching brief on those 3 things and making sure we have the balance right. And really, that's our key objective for the year, is making sure we have that balance right between the 3. But a few kind of key things that I'll go through. So the reason why this year's plan is different than previous year's plan, and there is a couple of key differences. First one, the chair mentioned a moment ago, is that it is only a plan for the first half of the year, so April to September. We are expecting that, and that's nationally, that's not bespoke to Kettering or Northamptonshire, that's nationally. And I think that's really because the national team haven't as yet and are still working through what the assumptions are going through winter. Is there going to be another COVID wave? What's going to happen with flu? And there are some really close eyes. I was on a regional call yesterday, really close attention being paid to Australia at the moment and what's happening out there, because normally whatever happens in Australia throughout our summer is kind of what tends to happen in this country over our winter. So We are expecting some guidance on what are the assumptions that they think are going to happen with those kind of things as we get closer to September, so throughout the summer, and we'll then be doing a winter plan for the second half of the year. So that's one key difference. Second key difference is that no longer are we submitting organisational plans. So I'm just going to turn my camera off because I lost you for a moment. So it used to be that Kettering Hospital submitted its plan as did every other hospital. This year, all we're doing is submitting our organisational plan into the system. So Northamptonshire as an ICS and as a STP at the moment. Now, the system then collates all of those from all the different providers and from the CCG, and we submit a Northamptonshire plan as a whole. So the conversations, as I said, I was on a regional call yesterday. Conversations from NHSE regionally and from the centre have started to turn. So they aren't asking how many waiting times Kettering Hospital has or what Northampton Hospital's 52-week position is. They are asking what the county's position is. And we are having to respond as a county. So there are some key drivers there for working together with our partners and coming together much closely so we all understand the position of all of the providers in the county, and we start to work together to deliver that care for our patients and for our staff equitably across the county. So some real strong drivers there. One example, which I'll just dwell on for a moment, is what we call the ERF, that's in your packs, which is the Elective Recovery Fund. So that is a financial incentive that the government has released guidance on, that the closer you can get to delivering activity levels you were at pre-COVID, so when they compare you to 2019, the more financial reward that you'll get for that. And you can see some of those projections as to what we think we'll be doing as a system in your packs. But basically, ERF is not calculated at organisational level. It is only counted at system level. So if Kettering Hospital goes great guns and gets up to doing the exact level of activities that we were doing in 2019, but Northampton General really doesn't because it's really struggling with staff or being able to protect green pathways, then as a system, we will not get access to that ERF. And that's really important because it really ties together how we're going to be working going forward to make the best use of capacity across the system. And that ties into one of my roles, really. So I do chair the System Elective Care Board. So we have a monthly System Elective Care Board, and we have, everybody comes to that. So we have both Kettering and Northampton, but we also have the independent sector providers in the county, and we have our commissioners, and we have primary care, and we have community and mental health. And really what we're trying to do at that board across the county is exactly answer the kind of things I've been talking about. Where is the capacity across the county? Who has spare theatre capacity? Who has spare outpatient capacity? And how can we work together to make the most use of that across the county to make sure that patients, regardless of whether you live in Daventry or you live in Corby, you're getting the same access to care across the county, both in terms of access times and waiting times, but also outcomes of care. And that's a key thing. So how are we making sure that it's not a postcode lottery about where you've been referred into as to whether you get access to a particular consultant or a particular subspecialty interest? Actually, every patient in the county should have the same ability to access those things and access high quality care. So that's what that System Elective Care Board is going to be doing. In terms of a little bit of a detail as to what we're setting ourselves, we are confident both at an organisational level at Kettering and also at a system level that the plans we are submitting are robust. So they are realistic. We think we can achieve it, but they are also robust and they are also fairly ambitious. We think there are some opportunities to go further, and I'll come on to that in a moment, but there are also some risks that we also need to consider. But as we move through our plans from April through to September, so that's where we stop because of the end of the first 6 months. As we move through that, our activity increases month on month. And that's because we've been able to bring some spare capacity back online safely. So at Kettering, for example, last week, we were able to open up some protected elective orthopaedic beds. So that's the first time since pre-COVID we've been able to have elective protected beds for orthopaedics. So we've been able to start to do hip and knee joint replacements, for example. You need protective beds for those kind of procedures because when they're going deep down into your bone, the risk of infection can be very high. So we need to make sure we're protecting those patients from usual emergency patients. So we've only started to do that last week at the end of May. At Northampton, I think they are planning to open next week, or it might have been yesterday actually, I can't quite remember the date, that they are being able to open another one of their theatres, for example. So as you go through the months, that's why you start to see our activity increasing throughout the months. But we are making sure that we are working with infection control, and we are happy that we can do that safely. In terms of some of the risks to those plans then, the key risk really is the resilience of our theatre staff. As I say, it's the theatre staff and the ODP staff across the NHS that moved into ITUs throughout the last year, and they've been working in ITUs to support the COVID response because the kind of skills that they have are very similar to ITU level skills. So they're now coming back into theatres, but of course they've had a really difficult year. So we need to make sure that they are resilient and they are protected as we ask them to continue to increase the number of elective procedures that they're doing. The second key risk is on our elective beds that I just described and being able to protect some of our elective beds. We are seeing, I think it might have come out earlier, we are seeing increases across the county and across the country on patients accessing A&E. I was on the phone to EMAS, the East Midlands Ambulance Service, last night actually, and they said there is a national problem at the moment. Ambulances are really, really busy. A&E departments are really, really busy. If we continue to see that, of course, that may compromise our ability to protect our elective beds because we need to provide beds to the highest clinical priority patients, and those are often likely our emergency patients. So as we move throughout winter, we need to keep an eye on that, and that's a key risk to our elective recovery. The other key risk to our waiting times really is what we're calling latent demand. So those are, and I'm sure you've read about that in the press, those are patients who we all think haven't accessed their GP over the last year for reasons that obviously we all understand. Now, if those patients do start to come forward in higher numbers, patients that really should have accessed care earlier on last year for perhaps potential cancer symptoms or other symptoms. And if we start to see a big wave of those patients coming forward, then of course that will impact on our waiting times and on some of our less clinically urgent patients getting the treatment they need, because if we would of course prioritise clinical priority, which would be suspected cancer over and above other patients. So that is another risk. But we do have some opportunities. So in this county, we do have some spare extra capacity at the moment. We do have some theatre capacity in terms of theatre space that at the moment we aren't able to staff because of reductions in our theatre staffing and ODP levels. That's not actual reduction though, we've always had that vacancy level. We used to fill it with agency staff, and agency staff are now no longer in abundance for theatre and ODPs. So we're currently working with our system partners, our independent sector partners and Leicester as to how we can start to use some of that capacity. Another key one is our independent sector. So this county works very well with our independent sector partners to use their capacity. We're continuing to do that, and there might be some more opportunities throughout the year as to how we do that. And the final one is some of our theatre productivity and our GIRFT, which is getting it right first time. That's a national efficiency programme that goes right from primary care, right from GPs, all the way through to community care and follow-ups, and benchmarks you as to what you can do, gives you advice as to what you can do to streamline those pathways and bring some efficiencies for patients in there. So we've already started to engage with our regional team, and we've got some reviews set up on our pathways next week. So we've got, I think, ENT and orthopaedics next week, and then we've got other specialties throughout the next month or two, where we'll be taking the lessons learned that they can offer and embedding that locally. And the final one is the system PTL, system waiting list. So we've started work on that. Previously, every organisation holds its own waiting list, but what we're trying to now do, and Andy Callow is leading that across the county, is bring together those waiting lists so we have a system view of it. What that will help do, it will help our GP colleagues, and they're in full support of this, it will help our GP colleagues manage patients and support patients before they get access and whilst they're still on our waiting lists. It will also help us across providers see where waiting times are at their lowest and be able to capitalise on that and send the next batch of patients where the waiting times are lowest. So we can start to hopefully across the county improve where we are with that. So that's probably enough from me. That's where we are with our elective waiting times. I've given you a little bit of a flavour as to how that's working at Kettering. And I think Trevor, actually without repeating what Trevor said earlier, because I think that was a really helpful Kettering specific summary as to our operational performance and some of our waiting times in our 52 weeks that we've got. So I won't repeat that. But I'll hand over to Anil, who's hopefully on the call. I can't see him. Anil, do you want to give a flavour as to how what I've just said impacts on our financial plan and some of our workforce assumptions?
Yeah, absolutely. Thank you, Polly. Good morning, everybody. So again, in order to deliver everything that Polly just talked about in terms of activity, performance, etc., and again, it is very much system-based, is looking at our workforce, our staff, and how that impacts on the finances. So again, if we look at our staffing, it's very much around a people plan, and it's a system people plan. And as part of that, obviously, we're looking at what workforce we have now, what workforce we need going forward, and how we balance our staff well-being and recognise that we need additional workforce and staff to support the delivery of the activity. In the meantime, that also supports the reduction in agency, and therefore is also an opportunity to reduce our cost base and therefore make some savings to manage our money and our workforce and our activity jointly as a triangulation piece. So in terms of staffing, again, the system have developed a workforce plan, recognising what's required to deliver the activity that Polly just talked about. As part of that, there's been a significant increase that we submitted as part of our planning process. So there's two key questions that we've been asked as a system. One is, what are you looking at in terms of recruitment, in terms of your existing vacancies, and how you're looking to fill that and manage that better going forward? And secondly, what's the reason for the additional investment we're making? So as a system, we're making about another 582 whole-time equivalents or 582 staff on top of the existing workforce we have. And that's to support the delivery of the activity and recognising three key elements. The fact is we've got the COVID impact and how do we support managing COVID and the changes in service and the way we've had to provide those, and also recognising investments we need to make as hospitals as across the system. So part of that has been reviewing those two elements. So from a KGH perspective, what we do recognise is we have about an 8% vacancy factor right now. So we have a 8% gap in our actual staff that we really need. We want to cover that through agency, but through the recruitment plans we've now got, we want to reduce that over H1 to about 5%. So there's a really clear recruitment plan around recruiting additional nurses, HCAs, etc., which is about 70% of our vacancies. So that's a key part. And a key part of that is both about recruiting staff within the country, but also using international recruitment as an opportunity to do that as well. So as part of that, we've reviewed and done a stress test to look at what all those investments are and what they are required to deliver. And they're mainly related to the fact that we need to improve our staff and well-being, but also because we've got some requirements around our patient safety, mandated safety, changes we need to make around maternity services, strategic priorities like ICANN and academic strategy, and also supporting part elements of our group plan around equality, diversity and inclusion. So on the back of all of that, we've recognised that we've got an opportunity over the next 6 months to look at our recruitment plans, use international recruitment, and therefore reduce our agency and therefore support ourselves by having more staff in post to support the delivery that Polly's talked about. So that's a key aspect of the workforce and the stress testing review that we've done. In terms of the finances, what you'll see is in the pack is very much about making sure we triangulate and balance and recognise the activity we expect to deliver, and therefore the ERF income that we could deliver of 2.8 million for ourselves, 6.6 million for the group, and how that triangulates both the workforce plans we have, our activity plans, and how that's reflected in the financial plans. So all three are aligned, and that's a key element of the plan that we've developed. It's very much a bottom-up plan to make sure it all triangulates, and it's recognised that it's also at a system level. So again, Polly talked about it earlier. Our system plan is also, from a finance point of view, seen as an overall organisational across the piece as a system plan. That's a break even for H1. So each individual organisation within the system is also agreeing and developed a break-even plan. So as a system, we aim to break even. So if one organisation results in a deficit, the other partners in the system would even make a surplus, but it is very much a system performance piece rather than an individual organisational piece. So how does that plan get derived? So it's very much based on the activity that we plan to do within our current baseline capacity and the workforce that we've now developed in order to deliver that. And then what it doesn't do is make any assumption around the latent demand and the referrals, and Polly talked about that earlier. So it doesn't take any assumption around that, and it doesn't include any COVID wave 3 either. What it does do is assume a level of ERF will be delivered to deliver that break-even plan. That's about 6.6 million across NGH and KGH, 2.8 million for ourselves at Kettering. It also means we've got to deliver a level of savings this year to hit that break even. So there's about £3 million worth of savings or cost reduction we expect to make, or efficiency of productivity in the first 6 months. And that's also part of that plan. Now, what we're looking to do is also make sure we have a longer term view around the financial plan, not just 6 months. Albeit at the minute is a 6-month plan for the system in terms of where we end up this year. We also need to look at where we are longer term. How sustainable are we as a system and as a trust? Now, we've done a 12-month plan or a longer 3-year plan developed on the back of that, which shows that we've currently got an underlying deficit. Now, we do need to look at how we improve that over the longer term. So there is an expectation from NHSEI, etc., that we will look at improving our underlying position beyond the 6 months into 12 months and going forward. That's not part of H1, but we still need to look at that. We've also got a capital plan for this year. So again, it's very much a system approach around capital investment. The capital investment is about 40 million for the partners. We've all agreed allocations around that and where we need to prioritise our investment in terms of estate, equipment, etc. And our share at KGH is about 13.4 million. And we've got a plan now developed as to how we want to invest that in the estate and at the trust. So a number of key risks, Polly talked about them earlier. The number of key risks from a financial perspective, delivering that break-even H1 position, are recognising there may be COVID wave 3 and how would we mitigate that? We need to make sure we have the workforce available in order to deliver the activity. So the workforce, if they aren't available, would result in increased agency costs. So we need to look at managing our workforce to ensure that is available for us to break even. And again, Polly talked about it, but in terms of that activity, we need to deliver the activity plan that we have in order to recover the ERF income in order for the system to then get back to the break even. And again, Polly mentioned it earlier, it's about an ERF system position, not an organisational one, but we need to recognise that. And I touched on efficiency as well. So as a system, we have savings targets that require us to deliver cost reductions and more efficiency and productivity through H1. And that again is ensuring we have those plans in place and the implementation of those plans to deliver H1. So the key elements in terms of what we need to do taking going forward is very much recognise the balancing impact of delivering the care to our patients, our workforce and the pounds to make sure they are managed and triangulated through the next 6 months, recognising each one of those will have an impact on the financial position or the staff or the workforce or our activity, depending on which one is being pulled. We are going to reinstate workforce management meetings so we ensure our staff are looked after and we are recruiting the people that we need to deliver the activity. And we're going to have efficiency schemes managed in a detailed, robust way across the system and also at the trust going forward. And we look at weekly performance management to look at how we deliver all 3 aspects of our overall plan. That's kind of a summary on the people and the finances. I'm sure Polly and I will be happy to take any questions if there are any.
Okay, that's a lot of long, complicated stuff, really, but that is how Kettering and Northampton or the system, and particularly Kettering, are responding to the NHS mandate, which Polly talked about at the beginning, the Secretary of State's instruction to the NHS for the year. So, any comments or questions at all on any of that stuff? Peter.
Thank you, Alan. A little while ago, when we had one of these meetings, there was a comment made, and I'm not sure it was yourself or someone like Simon, was talking about having some guidance coming out of NHS providers as to how governors can engage with the system. I haven't seen that, and it was due to come out at the beginning of May, I understand. Have we had any news as to where that is?
No, we haven't. I think it was actually advice from NHS England rather than NHS providers.
Oh, sorry.
But no, it was promised at the beginning of May, And like many things, when suddenly you start to write the guidance and people start to comment on it, people realise it's a bit more complicated than they thought it was. I don't know if anybody has any information on that. Richard is usually the source of all wisdom on things like that, but I don't see him responding anywhere. No, so the short answer for me is no, we haven't had any more on that. Still expected.
No.
Okay,
Okay, thank you.
No, not seeing anybody at all. Okay, thank you very much. Thank you guys for that. I mentioned the SDC had done sustainable travel plan. We have it's a big long bit of work, but we've only got 5 minutes on the agenda for it, although we are a little bit early. So Richard, are you there yet to do the sustainable travel plan?
Hello, yes.
Yes, good.
Yes,
Thank you.
yes, I'm here. Yeah.
So
So thank you. Thank you for inviting me along today. We've shared with the Council of Governors the Sustainable Travel Plan, which includes within it an action plan for sustainable travel. By way of a kind of recap, the purpose of having the travel plan is that it's to essentially look at how we can improve access onto the KGH site, whilst also taking account of the redevelopment that's planned, to enable effective coordination with our partners. And I think one of the really positive things that's come out of developing the Sustainable Travel Plan has been that we've engaged with previously Kettering Borough Council, but now Northamptonshire Council, in terms of having some contacts there with them around how we can try and integrate some of the things that we're hoping to do within the hospital to improve access with wider planning across the borough and council area, particularly linking in with their local cycling and walking improvement programme known as LC WIP, which we're hoping to get engaged with. I know that in the engagement that we undertook with some of our internal groups in developing the travel plan, concerns were raised about the availability of public transport going forward. And again, one of the positives of undertaking this piece of work is, again, we've linked in with the Northamptonshire Council on that too. And we're aware now of something called the Bus Service Improvement Plan. That's a government initiative that hopefully may give us a greater voice in future planning of bus routes in the future. And also we need to look at how we can reduce our carbon footprint. So any initiatives, and there are some included within the Sustainable Travel Plan, for reducing single car occupancy vehicles onto the site in future is also something that they're working on. To take the travel plan forward, we have a travel planning group. There are 3 of the governors on the travel planning group. We have a series of measures that we're trying to take forward that are listed within the Sustainable Travel Plan. And again, we're sort of monitoring and reporting back on that on a monthly basis, meetings of the travel planning group. And so some of the things that we're working on at the moment are how we might introduce, when it's safe to do so, car sharing initiatives amongst our staff to reduce single occupancy vehicles. And we have a number of apps that we're looking at the moment to take that forward. I've mentioned public transport in terms of how we're hoping to influence that in the future, and also how we might improve on publicity and initiatives around the availability of the voluntary car service to help our patients access the site. So there's a lot of work still going on. It is a live document. It's not something that we've produced to tick a box and to sit on a shelf. It's something that we will be working on over the next few months, and we will be reporting back to the Strategic Development Committee on a 6-monthly basis in terms of progress in delivery of the plan. Happy to take any questions.
Okay, thank you for that. I don't know, does any of the governors on that committee want to comment on that? No, not seeing any. Oh, wait a minute. No, still not seeing any hands. Ah, yes, I am. David.
apologies, the technology is now working. Richard, it's just a very brief point, really. Reading through the documentation there, it was talking about registration of vehicles and so forth, yeah, and that people would be limited to 2 vehicles. Given the fact that the hospital is has this ambition of being the most digitally advanced hospital in the UK within the next couple of years, I was thinking that it might actually be quite useful to have some kind of app or application that people can actually temporarily change that. And I'm just thinking about situations for myself, for example, you call up the garage, they deliver a car, they pick yours up. You've got a car that's not registered, but you've got to go into work, okay? And when my kids were at home, there were 6 cars on the driveway. I would often just pick up the first one that was there if I couldn't get out, if they'd been a bit lax in their parking, and drive. And I just think it's one of those things. It's a very small thing, but if you happen to be in a hurry one day and you've got a loan car or something, it can be really frustrating if you can't sort of access things and so forth. So it's just one of those very minor points.
Okay, thank you. I can talk through. We have on the travel planning group a representative of the car park management organisation as well. So yes, we can feed that back through to them.
Okay, thank you very much. All helpful stuff. Oh, another hand. Wait a minute, Peter.
Yeah, sorry to delay this, Alan, but there's just a small point which I think is perhaps just to sit in the margin for a while, and that is the question of electric vehicle charging on site. And we had a little bit of debate, and I've contacted Richard since the meeting, but there has been a thought about providing a lot of public car parking with electric charging points to facilitate people who are buying electric cars. I think it's something that the Trust needs to make a decision about, because as Richard, I think, said at one of the meetings, we don't provide petrol pumps for those people who have ordinary petrol-driven cars. So why should we provide an electric place? If you come into the hospital with an electric car, surely you're going to make sure it's charged up. So as I say, it's not so much a question. I think it's just something to sit in the margin, to have a discussion about at some future time, possibly at the Trust level, not just at the committee level.
No, thank you, Peter. Simon and I have had a number of conversations about this. In a clear way, the expectation is rising, whether that's in commercial shopping centres or other places, for charging points. And of course, there are people who will find it extremely difficult to charge their cars at home if they live in apartment blocks or terraced houses without car parking and so on and so forth. So part of the government's strategy clearly points in that direction. And it's harder to tell on the lower deck of the car park, but on the upper deck, there seems an awful lot of electric cars appearing from our staff. And I know Simon has one, and I have one now. You know, those are very real issues. So the question in many ways is the pricing for this. The pricing is a really difficult question. You know, we don't want to price it in a way that means the public think it's a great place to go charge their car. But on the other hand, we don't want to make a profit from our staff, or an undue profit from our staff. So the whole thing, you're right, it requires a complicated little debate, but we're clearly in the territory of electric charging points going forward. Got a couple of comments in there. That's always generates a little comment. So Chris and then Graham.
Alan, you may find it's a planning condition.
Yes, Chris, you're absolutely right. The local authorities are adopting some national guidance, aren't they, from a planning point of view? So you're absolutely right in that. Thank you for that comment. Graham.
Didn't want to unmute. Yeah. Chris is right. It almost certainly will be a planning condition. I'm not on the planning committee, but it certainly will. The difference with electric cars, of course, most of them are not fully electric. Most of them are hybrid, and you only get 20 miles out of sometimes less out of the hybrids, and it takes so long to charge. So if you were to charge a fully electric car overnight domestically, it's 8 to 11 hours. It's not like going to a petrol station where in 5 minutes you've filled up for another 300 miles. So that there's a big difference. And you know, if somebody's had to come 20 miles, they've used up all their hybrid electricity and they're back on petrol. So, and anyway, there are a number of companies out there will do it. I'm sure it'll be cost neutral, at least for the hospital, but with some of the deals that are going, and some of the incentives that are around. I think it's important that it's done, if only to encourage people to switch, because we're only 9 years away from stopping selling internal combustion engine cars.
No, yeah, you're absolutely right, Graham. And we'd want to do our part to contribute to the drive for green. Polly's already talked about being green champion. You know, much of the travel plan was about bicycle storage and bicycle e-bikes and bicycle rental. And we know we've got to do this. And Simon, as I say, Simon and I have had a few conversations about the best way to think about it and trigger the bit of thinking that's necessary to work out how to do it. I think my biggest concern is that members of the public think it's a great place to charge and fill up our car parks. I think he has other slightly bigger concerns about it. So the pricing, not so much worried about it being cost neutral to us, I'm worried about the consequential effects on people's behaviour from the pricing mechanisms in my case. But anyway, thank you for all those comments, very helpful. Those of you who are involved in the travel plan will no doubt keep talking to governors. Thank you, Richard. I'm going to jump now to item 8 because I'm getting a bit nervous about Trevor's time. So I think, Peter, you chair this item. Would you like to just pick it up and take it forward?
This is Gail. Gail chairs the Appointments and Remuneration Committee.
That's fine. It's not a problem. The group met on the 20th of May and we received the objectives of our trust chair, Alan, and we approved those. So they've come to the meeting today, submission for final sign off. So unless there's any questions from other governors or any comments that Trevor or Peter would like to make, simply for approval. Silence.
I would suggest the governors accept these on the basis of how they've been drafted. Trevor and I did quite a bit of work with the chair, and it's all documented there. And I think it's a piece of work that I would suggest that we take it forward for the 6-month review and pass it through this committee today. I don't see any objections to that.
Yeah, agreed.
Thank you, Graham. So that's agreed on all accounts. Thank you.
Do you want to take forward the next bit? Because it's really your bit, 7.2 and 7.3 on the agenda are all yours, guys.
Okay, so we're then on to the non-executive director annual appraisals. Alan was in attendance and presented an update to the group. Again, we all received those and they were signed off and approved. So as per the last item, it simply come to the Council of Governors for a final sign off, unless anyone has any additional comments.
I agree.
Silence reigns.
I agree. Okay, that's that one dealt with. Gail, thank you.
Okay, thank you. And then we move on to expiry of non-executive directors' terms of office. We had both Lise and Damien who attended for their relevant section, and again we endorsed an extension and recommendation for both of these non-executive directors to serve for a further term of office. So again, that was approved by the group and has been submitted for final sign-off.
I accept that. Thank you.
Okay, thank you very much.
Okay,
that's all,
very much. Thank you, Peter. Thank you, Gail. I think you're there on that. The University NED appointment, my update on that is we're still in ongoing conversations with the university. They're going through quite a lot of changes. The representative at Leicester, at Northampton, has become head of school, so he will be moving to be traditionally on the board of Leicester Hospitals. So we will be getting new nominees, and I think the university still wants to think carefully about who those nominees are and what it is that would best benefit them and us. So we're still in conversation. We haven't quite got an answer to that yet, but as soon as we do, we'll come back and do what we agreed to do with the governors on that appointment, and that is have a conversation with the candidate, as I recall. Okay, anything on that at all? I don't see anything there. Thank you. Now, sorry, lost a bit of paper. The quality report. Helen, are you there?
I am indeed. Good morning.
Good morning. Would you like to run through the quality report for us, please?
I certainly will. So, hello. For those that don't know me, my name is Helen Mills. I'm the Quality and Compliance Manager, and I've been coordinating, pulling together the quality report for the Trust for this year. As some of you may know, this is normally a mandatory report as part of the annual reports. However, for last year and this year, it is not mandated to be part of the annual report, but obviously we have continued to develop this. So I've engaged with various people across the organisation to get their end of year summary, and we've also done some engagement in selecting some quality priorities for the forthcoming year. I believe Manisha has invited some governors to a meeting on Monday to allow for a further in-depth conversation should it be required. But I came today to obviously consult with you about the quality report and seek your views and opinions on it, please.
Okay. You have the report, I think. So any comments or anything on our quality report? Chris mentioned it earlier as a good read. It's a good big read anyway.
Yes.
Gail.
Thank you, Alan. Just the comment, as I said earlier, and Helen may not have been present, similar to our discussions from last year with regards to a summary, Helen, because of the detail within the report, the length of it, for members of the public. So something a little bit easier to read and understand.
Are you talking for the entire report or for the priorities?
No, I mean, that would be an awful lot of work to go into that level of detail. But no, an overarching summary that will give them the highlights, and that then if they want to go into the detail, they can.
Okay, yes, I can look at doing that. There's quite a lot in the Chief Exec's opening book that summarises quite a bit within it. It does actually talk about some of the successes and how we've done on various performance. That's kind of within the Chief Exec summary.
Right. I mean, other governors may have a comment, but we can talk that through when we meet
on Monday.
at the meeting, whatever, if there's anything specific. Thank you.
Okay, thank you, Gail.
Thanks, Gail. That's helpful. And I'm sure Helen's picked up that point. Anybody else at all want to talk about quality report? No. No. Okay. So annual report, and Helen's already mentioned it was would have been a part of it. Can I just remind you that the report at the moment is confidential. It's a draft report and it needs to go through a number of processes. Feedback to Richard May by Friday the 18th, please, if you have any on it at all. I think you have seen that as well. Any comments at all on the annual report and what happened there? No. Right. Any comments at all on the annual report in its current form? No. Anyway, when you're reading it up to the 18th to comment on that, and then the audit report will take it through the processes for that. Okay, thank you very much. Governor appointments. David has resigned from the Appointments Remuneration Group and as from his nominated governor positions on a number of committees. So we have vacancies for the Deputy Nominated Governor on Group Digital, the Deputy Governor on Group People, and a member of the Appointments and Remuneration Group. I don't know how you want to take this forward. Do you want to seek nominations over the next week or two, and then, if necessary, the support team will run elections? Or yes, Peter's nodding. So can we send it out to all governors, guys, asking them to self-nominate or nominate somebody else if they feel particularly vindictive, and send it off to us? And if we've got more than one candidate, we'll have a chat with the lead governor, and if that produces an election, then that's what will happen. Are you happy with that? Yes,
yeah,
you are.
That's spot on, Alan. Spot on.
Okay, thank you very much indeed. Is there anything else at all anybody would like to raise? Or you're about to get 40 minutes of your life back unexpectedly? No, nothing. Oh, wait a minute, I got one. I can't quite see who it is yet. David.
Okay. Apologies, I had a few technical issues earlier. There's just one point I'd like to raise. I'd like to just go back to the digital side of things. I've noticed over the last number of months a number of issues with outages of IT, not just infrastructure, but also software. And it's become a little bit concerning. And the reason for that is that when I first got involved, I spoke to Alice and I asked the question, had there been any case-based simulations to test the software to make sure it was fit for purpose? And had it been appropriately stress tested? And I was told no. And we had a little discussion like that, and I just left it. Subsequently to that, it then turned out that a number of software upgrades had been installed and they had to be rolled back. And the comment that was made then was that it had not been tested adequately because they didn't have the tools to do automated testing. And if you're actually going through a series of upgrades, the standard process is that you build test packs and you run these automatically, and it just shortened the duration of testing. And I've noticed recently there have been a number of rollbacks of software, which would suggest that the testing issue is not being resolved. It's a little bit concerning because as things roll forward and your operation becomes more and more dependent upon the IT, those outages are going to have more significant problems than they currently do. And although you've got paper-based solutions and so forth in place, over time, they are likely to break down. That's just the nature of the beast, unfortunately. So I would just raise that, and I would ask that whoever is appropriate within the board actually take that forward and just at the next meeting give us some reassurance that these issues are being addressed. And I think it also at that time would be quite useful as well to understand the how the approach in terms of the robustness of the system is being tackled in terms of whether it's fault tolerant or high availability, because they're very different. And it may not be appropriate for fault tolerance to be applied to all aspects of it, but there probably are areas where it needs to be applied. I just think if these issues are not addressed, then as time rolls on, there's a bit of a nasty waiting down the line. So I'd encourage people to have a look what's going on there. That's what I have to say.
Thank you very much for that. I suspect that's rather a specific question that might need best handled by the Digital Hospital Committee and by the digital team. I see Debbie's hand is up, however. Debbie.
Yeah, thanks, Chair. So I think there's a couple of things in there. So thank you for raising that, David. The first one is with regards to upgrades. So it's something that I've already picked up. We should have a test environment in place, and that's either by the supplier itself or internally, and it doesn't necessarily need both. So
can I just come in, Debbie? I think with all due respect to that, you can't rely on the supplier.
Yeah.
Guys, we're not having the debate here on this now. This is a complicated reassurance issue, and it's a good issue to raise, David, but we're not going to have the debate here, I don't think. I think it's the complication of the assurance and reassurance that governors are looking for here, and indeed board members. So I am aware of where we have test facilities, and I'm fully aware. I'm surprised at the answers you received, David, but we can certainly pursue that. I think that's the point Debbie's making, because the answers don't reflect the reality about how we test this data in test environments and so on. But we will take that into the Digital Hospital Committee, and I'll ask Alice and or Andy to make sure we can respond at the next governors meeting, because the point you make is a valid one. Mabel.
I'm sorry to ask another question. It's a question that people have asked me recently. What's the carbon footprint of their hospital and how's it measured? Because I've got no idea.
I think that might be another question where notice is required of people. It's a perfectly good question. And we're in the business of carbon footprinting, and we are in the business of reducing it. Much of the conversation in the Strategic Development Committee has been about it. Who's my expert on carbon? I suspect, again, that we don't have an answer for that. We will get back to you on that one. We will raise that issue with the way we think about that. I have no idea either how you measure carbon footprint. I suspect it's rather more complicated than size 11 anyway. So
I think it starts with Ian. I think it starts with Ian Allen.
Peter Williscroft will be an expert on this. Peter.
I knew I should have kept quiet.
Yeah, you should have done.
I think it's probably something that should be rested on Alan's shoulders, Ian Allen's shoulders, because it's more or less his bailiwick, but I'm sure he'll fend it off to someone else. But I would say it starts there.
We'll come back to you anyway. Richard has his hand up to you. Richard.
So yeah, Alan, I think you're spot on. That's something for the Strategic Development Committee to look into. So good luck with that. But it is an ambition of the group to get to net zero by 2040, which is a national incentive, national programme for all NHS organisations. What I can tell you, Mabel, is that we do an awful lot of work on the not so obvious side of things. So around recycling, zero waste to landfill last year. Absolutely none of our rubbish went in landfill last year. We recycled a good proportion of it, and the rest of it goes in a waste to energy process. So there's an awful lot of good work going on in estates. But what is our carbon footprint and what's the plan to get it lower is a much broader question than what I'm able to tell you today.
Okay, that's helpful, Richard. Two things. Can you make sure it's on the agenda, as I'm sure you will, for the SDC? Mabel, or other governors, Peter, other governors, would you like something on our carbon footprint and how it's done at a future council meeting? It doesn't need to be a long bit. Yes, says Mabel. Yeah.
Well, I think that's the question's been asked, Alan. Then yes, please.
Okay, thank you very much for that. And obviously, we'll come back with some answers on the points made about data testing and data reliability. David, your hand is still up. Is that a legacy hand or a new issue? No, nothing there. Okay, I'm assuming it's a legacy hand. Right, the next meeting is, that's a very good question. 1st September, Wednesday the 1st September is the next Council of Governor meeting. We have lots of events in between, many of which have been referenced today. Are we all done?
Yes.
Thank you very much for your time and contribution, everybody. Very nice to see you. Go and enjoy the sunshine. Thank you.